Cellulitis is an acute, spreading, bacterial infection of the dermis and subcutaneous tissues, characterized by pain, erythema, warmth, and swelling, usually with indistinct margins. It is non-suppurative, no pus, and typically affects the lower limbs, but can occur anywhere on the body. Microbe-causative organisms. Most infections are due to gram-positive cocci, especially. Organism characteristics of Streptococcus pyogenes. Most common cause, rapid spread via lymphatic Staphylococcus aureus, more localized, associated with abscess or trauma. MRSA consider in hospital-acquired or recurrent cases. Gram-negative bacilli seen in immunocompromised or diabetic patients. Risk and predisposing factors. Breaches in skin, trauma, insect bites, ulcers, eczema. Diabetes mellitus. Peripheral vascular disease. Lymphedema. Obesity. Venous insufficiency. Immunosuppression. Tinea pedis, fungal foot infection, common portal of entry. Microscope pathophysiology. Bacteria enter via a break in the skin, invade dermis and subcutaneous fat, cause acute inflammation, redness, swelling, heat, and pain, can spread via lymphatics, leading to lymphangitis. Severe infections may extend into deep fascia or result in bacteremia/sepsis. Clipboard clinical features. Symptoms/sign description. Local signs: erythema, warmth, swelling, tenderness, ill-defined edges, pain often present, maybe throbbing fever, chills. Systemic features may indicate bacteremia, lymphangitis. Red streaking proximally from site of infection, regional lymphadenopathy. Enlarged draining lymph nodes. Skin may blister in more severe infections. Receipt differential diagnosis. Condition key difference from cellulitis. Erysipelas. More superficial, raised lesion, well-demarcated DVT. No erythema, pain on dorsiflexion, Holman's sign, necrotizing fasciitis, rapid progression, severe pain, crepitus, systemic toxicity, contact dermatitis. No systemic symptoms, itching, common abscess, localized fluctuant swelling with pus. Test tube investigations. Though diagnosis is clinical, supportive investigations may include CBC/WBC count, CRP, ESR raised in acute inflammation, blood cultures if febrile/systemic signs, swab or culture from any open wound/ulcer, ultrasound to rule out abscess or DVT, MRI/CT if deep infection or necrotizing fasciitis suspected. Pill treatment. Hospital general measures. Rest and elevation of the limb. Analgesia, paracetamol or NSAIDs. Hydration. Syringe antibiotic therapy. Empirical, then tailored based on culture. Severity treatment: mild/moderate oral flucloxacillin or amoxicillin, clavulanate, penicillin, allergy, erythromycin, clarithromycin, or clindamycin. Severe/systemic 4-flucloxacillin, cefazolin, or vancomycin if MRSA suspected. Diabetic/immunocompromised may require broader gram-negative and anaerobic coverage. Duration, typically 5 to 10 days, may be extended based on response. Hammer and wrench surgical management. Only if abscess forms, needs incision and drainage. Necrotizing fasciitis suspected, urgent debridement. Ulceration/chronic wound, surgical debridement. Cyclone complications. Complication description: abscess formation due to localized pus collection, sepsis especially in elderly or immunocompromised, lymphangitis, red streaking, systemic illness, chronic lymphedema, repeated cellulitis, damages lymphatics, recurrent cellulitis especially in diabetics or with venous disease, necrotizing fasciitis, rapidly spreading, life-threatening. Counterclockwise arrows button. Recurrent cellulitis, prevention. Treat fungal infections, tinea pedis. Weight loss in obese patients. Compression stockings for venous insufficiency. Skin hygiene and moisturizing. Prophylactic antibiotics, penicillin V in recurrent cases. Baby, old woman age group affected. Can affect any age, but more common in elderly, due to circulation problems.